before. So that brings us to IV iron. And will IV iron bypass this whole issue of iron absorption and bioavailability? Now, there are many different iron combinations or preparations that are available out there. The issue is that some of them have not been tested or never been tested in large outcomes trials. So we don't necessarily know exactly both their safety and their tolerability, although there are some data from other studies in adjacent patient population like CKD or observational data in secondary analyses, but we truly don't know necessarily the dose or the safety of these preparations. And remember that there were all of these concerns about anaphylactic reactions with earlier preparations with iron as well. Because of the moiety in which iron was packaged. So the most data that we have is ferric carboxymaltose, and then we also have a large randomized controlled trial with ferric doryxymaltose, and I will go over those results as well. So the first study that really pushed this concept forward was the FAIR-HF trial. FAIR-HF trial was patients with heart failure ejection fraction less than or equal to 40%, used again the same criteria, ferritin less than 100. Now, ferritin less than 100 is a little bit of a problematic criteria, but let's hold off on that part till I come to the HeartFit trial. So the ferritin less than 100 or TSAT less than 20 if your ferritin is between 100 and 300. These patients were randomized to getting IV iron versus normal saline and follow them. This was not powered for clinical outcomes. This was a short-term study looking at primarily improvement in symptoms, functional capacity, quality of life. And this trial was a success. A significant improvement in patient reported global assessment, improvement in functional class, improvement in KCCQ scores, improvement in 6-minute walk test, and not only improvement, but the degree of improvement was pretty impressive. So about 10-point improvement in KCCQ and about a 30-meter improvement in 6-minute walk test. So positive results, but clinically meaningfully positive results. And then the last thing is that these measures were measured at 4, 12, and 24 weeks. And as you can see, the benefit was accrued pretty fast at 4 weeks and was persistent across the time frame up to 6 months where it was studied. Then this issue comes up of interaction with anemia. Again, Dr. Panjwat made a pretty cogent point that iron deficiency is an issue itself. Yes, there are more issues if you have iron deficiency anemia, but you don't need to be anemic in order for iron deficiency to be a problem, because iron is an important cofactor not only in your ATP generation, but also with multiple enzymatic functions along various different organ systems. So iron deficiency, irrespective of anemia, is theoretically important. And here we are showing data that it's not only theory, but empirically speaking, both patients with or without anemia benefited in terms of their symptoms and functional class as well. And as opposed to the iron out trial that I showed you with, really minimal changes between placebo versus treatment arm with oral iron in terms of improvement in ferritin or TSATs, here at the bottom of the slide, you can see the significant improvement and the difference in the placebo arm versus ferric carboxymaltose in terms of repletion of iron as manifested with week 24 results in increase in serum ferritin and TSATs. Okay, so this trial was named very well, Confirm-HF, because you needed to confirm the results of FAIR-HF. So this is a pretty similar trial, similar sort of inclusion-exclusion criteria. Again, ferric carboxymaltose was given to the patients and were followed long-term, and it really replicated all of the results. About a 30-meter difference in 6-minute walk test at week 24, a highly significant result. That result, again, was seen early and was persistent, and other measures beyond the usual quality of life scales or health status scales, things like fatigue score, all of those were substantially improved. Now, again, very much like FAIR-HF, this trial was not designed to look at clinical endpoint, but in secondary analysis, if you look at the clinical endpoint, there was a pretty substantial reduction in the risk of heart failure hospitalizations, and this should not come to us as a surprise, although this is a secondary analysis. Nevertheless, if iron deficiency is associated with poor cardiac function and iron repletion improves symptoms and cardiac function, one can expect improvement in overall health status, including reduction in heart failure hospitalization. And that is what we were seeing in the secondary analysis as well. Now, the quality improvement or health status improvement that we see in patients with any disease with medical therapy, that's a little bit of a difficult concept for our patients to grasp. Like what does a 3-point improvement on a scale mean to me as a patient? So it's common to do something called responder analysis. 5-point improvement in KCCQ is associated with a significant improvement that the patient feels. 10-point is sort of a wow improvement, and then 15-point is really very, very substantial improvement. And if you put the data together for FAIR-HF and confirm and look at this, something called a responder analysis, a threshold analysis, 5-point, 10-point, 15-point improvement in KCCQ, all of these were substantially in favor of iron therapy and a trend towards worsening with placebo. Okay, so now we know that oral iron really is not working tremendously well. We know that IV iron works, but we know it in the short-term trial. What about clinical outcomes and longer-term larger trials? So the first trial that came out in that realm was the AFFIRM-AHF, a large trial, almost 1,000 patients, but acute heart failure trial. So these were the patients who were admitted in the hospital setting who had iron deficiency, were repleted. And this was the primary endpoint. The primary endpoint, again, if you're a frequentist, you would be worried about a p-value of 0.059. If you're a Bayesian like myself, you would say, well, I mean, the results are self-evident. P-value of 0.049 versus 0.059 really doesn't make a difference, especially if you look at it in the totality of evidence perspective and look at the CONFIRM-AHF and FAIR-HF results as well. Nevertheless, as we all know that now we are all sort of post-COVID era, but there was an issue when these trials were being done, both with ferric dirysomaltose and ferric carboxymaltose, is that a lot of things had changed in terms of the protocol and heart failure hospitalizations rates, etc. So in AFFIRM-AHF, there was a pre-specified analysis adjusting for when COVID started. So at least from my perspective, this was a positive trial. But if somebody is really concerned about a p-value, when you look at COVID-adjusted analysis overall, the p-value then became 0.024, and this was pre-specified. So now you're definitely getting some evidence of reduction in heart failure hospitalization itself overall, not necessarily for cardiovascular mortality. The second study that looked at it was the Ironman trial with another preparation, ferric dirysomaltose, that also was patients with heart failure, longer-term outcomes study in this patient population, and almost showed sort of the same results in terms of the heart failure hospitalization or the clinical outcome. Same issue with the COVID, p-value marginally missed at p-value of 0.07. Again, very much like the trial of AFFIRM-AHF, pre-specified analysis was shown with COVID analysis. In this study, however, there was not as much quality of life scores that were improved. There were some issues with crossover as well. But the bottom line is that for clinical outcomes, pretty replicable results. And when you take into account COVID analysis, we are again seeing a statistically significant result overall.